Hello, I'm Dr. Rajiv Agarwal, Professor Emeritus of Medicine at Indiana University School of Medicine in Indianapolis, Indiana. This was a clinical trial called Confidence, and we asked the question whether if we initiate two drugs, empagliflozin and finerenone, simultaneously, would it produce a greater reduction in albuminuria at day 180 compared to finerenone alone or empagliflozin alone? The motivation was if we reduce the time to reduction in albuminuria, it might accrue greater lifetime benefit for the patient. But another reason was, is the combination therapy started simultaneously also safe in terms of hyperkalemia, the changes in blood pressure, and EGFR reduction? So the motivation was to look at both this safety and efficacy of the combined therapy compared to the monotherapies alone. The study was a double-blind, randomized controlled trial. It was conducted in 14 countries at many sites, and it employed a double dummy design. So each patient received two medications. One could be either empagliflozin, the other could be finerenone, or could be empagliflozin and placebo, or it could be finerenone and placebo. By having a double dummy design, the patient couldn't tell whether they're receiving both active medication or one was a blank pill. So this was the study design. We called the patients after randomization at day 14, 30, 190, and 180. At day 180, we stopped the study medication and we had them come back at day 210 to see if the treatment effects went away. The patient population was people with diabetes and chronic kidney disease being defined as UACR between 100 and 5,000, or EGFR between 30 and 90. We excluded patients who had potassium more than 4.8, who had type 1 diabetes, who had heart failure with reduced ejection fraction that was symptomatic, or those who had received MRA or an SGLT2 inhibitors in the 8 weeks prior to randomization. All patients had to be on a background of a maximally tolerated dose of an ACE inhibitor or angiotensin receptor blocker. The key findings were that the dual therapy, which was the combination of finerenone and empagliflozin, reduced albuminuria 52% at day 180. In fact, the combination therapy reduced albuminuria 30% at day 14. So the reduction in albuminuria was rapid and sustained. The primary endpoint was the comparison of the reduction in albuminuria compared to monotherapies, and compared to the monotherapies of empagliflozin and finerenone, the reduction in albuminuria was 29 to 32% more. Also importantly, there was no difference between empagliflozin or finerenone, which was not a primary comparison, but they are very much on top of each other. Here in this subanalysis, we are asking the question whether the GLP-1RA influences the treatment response and the safety of this strategy. 23% of the patients in this trial were on GLP-1RA. So we are comparing the 23% of people on GLP-1RA against the 77% of the people who are not on GLP-1RA. And the key findings there were that there were slight imbalances in the demographic characteristics. For example, the people who were on GLP-1RA were more often white, less often Asians. They had a higher body mass index. They also had treatments more treatment with statins, aspirin, antiplatelet agents, uh, and also insulin, but less treatment with DPP-4 inhibitors. Now, despite these differences in treatment characteristics and demographics, there was a similar reduction seen in the GLP-1 RA group compared to people who were not taking GLP-1 RA. In other words, the GLP-1 RA did not influence the treatment response to the drugs, finerenone, uh, um, empagliflozin, or the combination. Furthermore, we did not see any differences in adverse effects or serious adverse events in the trial in people who had GLP-1 RA or did not have GLP-1 RA. The clear message here is that all these treatments are additive. So first of all, everybody is on a background of ASO-ARB, and the two treatments, when started simultaneously, produce a 52% reduction in albuminuria. And this reduction in albuminuria is not influenced by GLP-1 RA use, which means that patients can expect to have additive reductions in albuminuria with each treatment. So it sort of supports the use of pillars of care that has been proposed by several people and organizations in the treatment of people with CKD and type 2 diabetes. Well, this is a predefined analysis of GLP-1 RA. We did not randomize patients to GLP-1 RA here. So a future study could be where patients are prospectively randomized to GLP-1 RA or not on GLP-1 RA and see if the treatment response is truly additive in a double-blind randomized trial. That would be the true test whether these therapies are truly additive. But as it appears now, it seems like it is.